I'm the director of production.
You're the
Guthrie colleagues here.
They're going to start now.
Go to the screen. After the screen, everyone.
Yeah.
Come back to.
Okay, you want to change seats?
Smile, Kirsten. Say hi. Okay. Oh, Mary Chris, you're going to want to move.
What's that? She's like right in the line, isn't she?
Yeah.
You can move your seat over here. Yeah.
An hour of you is too much.
Everybody back. You have to go around. That's cute.
Just your right eye.
Okay, good afternoon. We'll go ahead with the grand round today. This cycle's second grand round today. I hope you liked the last week's grand round. How many were present last week? Quite a few of you. So that was our guest speaker. And I'm sure you remember what he said. So today we have one of our residents from family medicine residency. And before that, I just want to go through a couple of housekeeping slides. And that's just in the way of information as to what we are trying to achieve this year with the grand round. So that's our goal, that we fashion our objectives and topics which covers and at least be beneficial in bridging the gap between primary care physicians and our specialists. And we do have some gaps, and accordingly we are moving along. We already have, these are the dates, as you see, the Fridays when we'll have the grand rounds. 37 of them in the whole year till next year, June. Some of them, about 9 or 10 of them are for residents and the fellows in cardiology. And about the same number guest speakers. So that brings us to about 20 grand rounds, and 17 are internal speakers and some others. So that's a good mix right there. In your evaluation form, and this was looked into our accreditation survey, as you see the upper right hand corner where there are 3 boxes which says today's topic confirmed my current practice or current knowledge about that subject, prompted me to consider changing, or enabled me to change. And all these 3 bullets have different meanings. For one topic, for one person, all 3 can be true. Something confirmed your knowledge and current practice, some will prompt you to change, and some convinced you as to enable that to change, confirm your practice, or you believe that so much after the presentation that you will do that. So, not all 3, but at least one you should be checking one of those boxes. And we go on and we derive meaning as far as outcome is concerned. It's very difficult to establish outcome, as you can understand, but this is one minor way of right away establishing outcome from those boxes, and that's called change index. So if the change index is below 0.5, then we have done pretty satisfactorily. If it is more than 0.8, then we have done an excellent job of producing outcomes. So that's what it means, and this was in a way of reminding you to check those boxes. Time is running out, so let me introduce today's speaker, Dr. Usman Ibrahim, and he had his undergraduate education in Dominican Republic, then went to Cayman Island. He had his medical degree from there. He is training with us in family medicine residency and will be staying with us. It's a good news from October this year as attending physician in outpatient and urgent care. He will be licensed in Pennsylvania and board certification. He has many other certifications before this. Member of many medical societies, had 2-3 outstanding presentations before this grand round today. And he has many hobbies, a full paragraph of hobbies. I'm not going to read that. But he has horseback riding. He will present today on HIV and the role of primary care. Again, I talked to him and he gave me a great answer about establishing the gap. And I said that as primary care doctors, we don't have many HIV patients. At least I don't see any HIV patient in my practice. Obviously, if there are in this area and this place, then they go to one specialist from our system who comes once a day in our clinic here in Red and does the HIV clinic, or it goes to the ID specialist. But he gave a great, and that's a great quote for my gap establishment, is that suppose somebody moved in here in this area and became your primary patient and has HIV and came to see you, then you will not know exactly what to do. So that is something which everyone should be aware of. And as the saying in medicine goes, that you should know everything about common problems and something about uncommon problems. So this is one of those things every primary care provider should know, whether they regularly practice seeing HIV patient or not. So without further ado, Dr. Ibrahim.
Good afternoon, everybody. My name is Muhammad Usman Ibrahim, and today is Friday the 13th, so no jinxing. As Dr. Sharma mentioned, I'm going to be presenting HIV infection, the role of primary care. So why are we discussing this topic? If a patient comes to a primary care physician, whether he's an internal medicine or family medicine physician or whatever, they are coming for an insurance physical and require standard screening for HIV. What if it came back positive? What is your responsibility? What is the up-to-date guidelines and say about what you should do? Well, or what if, like Dr. Sharma mentioned, that they have chronic HIV and they're coming to you for you to provide intermittent and chronic care for their other general medical conditions, and they just want refills of their other meds. Well, that actually happened to me in my first year, and I didn't know what to do. I didn't know if there was something extra special I needed to do for them for this particular patient population. So I didn't like the fact that I didn't know, and that's okay as a resident. And I'm sure a lot of other residents come across stuff like this as well. But that's the reason why, is because there's this practice gap, and some of the physicians training here may choose to go to more metropolitan areas where you will come across this more often. So like Dr. Sharma said, we'd like to know a little bit of something about less common issues. So let's move on. There's going to be a lot of slides today. It was originally 95 slides, and we had to cut it down to like 77 slides or so. So I apologize if we're going really quickly or moving through the slides too briefly. Obviously, I have no financial disclosures or conflicts of interest. The objective of this presentation is to discuss, obviously, the role of the primary care physician in the infected HIV patient, and broadly review the initial evaluation, clinical monitoring, and health maintenance, and focusing on some practice and screening guidelines from the Infectious Disease Society of America, the CDC, and the American Academy of Family Physician, or AAFP, key recommendations. So the primary care physician, what is our role? Well, we should be able to identify those who are at risk, detect those who are infected, and refer them for appropriate treatment, whether we are initiating it ourselves or co-managing it with an ID or HIV specialist. Continue to provide intermittent and chronic care, and when they're on antiretroviral therapy, recognize complications of the therapy and potential medication and drug interactions. So HIV is it a papillomavirus, lentivirus, herpes virus, BK virus, or a Jacobs-Creutzfeldt virus? And whoa, that's surprising. The majority of you answered right.
Three.
That's a little upsetting. I wanted to surprise some of you. So
Only 3 answered.
there was a timer on it. So next question, you guys got to press quickly. So HIV is a retrovirus from the genus Retroviridae and the species lentivirus. I didn't know that. So let's move on to the disease course. Here's a graphical, nice graphical depiction of the HIV viron as it infects the human body. This is specifically from the stratified squamous epithelium of the inner side of the penile foreskin. And from the time of inoculation to the time it disseminates into the body on an infected CD4 T cell, you can see that it could take up to 25, even 28 days before systemic dissemination in CD4 T cell reservoirs. So that's a little bit of an issue because there seems to be then some time lag before positive serological markers on standard diagnostic and screening tests come back positive. So we'll talk a little bit in the coming slides about what to do about that. But this is a list of some AIDS-defining illnesses. They're traditionally opportunistic infections, which if the patient ends up, HIV patient gets this, they are now defined as having AIDS, and some of them are, bronchial or tracheal candidiasis, extrapulmonary or disseminated coccidioidomycosis, cryptosporidiosis. I'm not going to go through all of them, but here's a nice organ systems anatomical depiction of what some of them are. HIV itself, the virus, it can cause disease itself, not just immune suppression and opportunistic infections. It can cause HIV wasting syndrome or AIDS dementia complex, which also can predispose to osteoporosis and osteoporotic bone fractures. Here's a question. We'll start the time as soon as we get to the options. HIV-infected woman has headache, fever, and seizure. Her CD4 count is 56, her white count is 3.2. MRI or CT shows a ring-enhancing lesion. She takes no medicines other than methadone. This is the CT showing that ring-enhancing lesion, and the question is, what is it? Is it a lymphoma? Is it toxoplasmosis, cryptococcosis, progressive multifocal leukoencephalopathy, or herpes simplex encephalitis? And the majority of you answered toxo, which is correct. Good. That is the right answer. Some of you answered lymphoma. Well, actually, this is lymphoma. Other CNS complications. This would be a space-occupying solitary lesion in a patient with primary CNS lymphoma. And typically, the CNS lymphoma would be more of a space-occupying lesion, which you can see is impinging because of that space. Here would be the typical bilateral interstitial infiltrates, which can be described as fluffy or ground glass appearance in the pneumocystis carinii pneumonia, now known as pneumocystis jirovecii pneumonia. Again, these are opportunistic infections. Some other opportunistic infections, complications such as oral HSV ulcer or oral candidiasis. So talking a little bit about transmission and epidemiology, we see that in the U.S. sexual contact remains the primary mode of HIV transmission, and it is most commonly transmitted among male-to-male sexual contact by far in the general population, and followed by heterosexual female contact, followed by heterosexual male contact, followed by male intravenous drug use, and then females. If we split it up between the sexes, we see, obviously in the male, if the majority is a male-to-male sexual contact in the general population, then in men, it's going to be that, followed by heterosexual contact. But in female, interestingly, it is the heterosexual contact, then followed by intravenous drug use. So this has a lot of implications for men and women. If we look at the races, there's a huge disparity amongst the races with the minority Black African American population, with these slides adapted from the CDC from 2008 to 2011. The percent of diagnosis was by far exceedingly affecting this population. Then whites had the second amount of HIV diagnosis, followed by Hispanic Latino. But if you look at rates of diagnosis, so as opposed to who has it versus who's getting it, again, the disparity is there with the Black African American population being mostly getting it. And then interestingly, you'll see that it's not the white population, although they're the second most who have it. In terms of who's getting it, it would be the Hispanic population of both sexes who is getting the disease more. And then interestingly, the Native Hawaiian and other Pacific Islanders is also exceeding the white population in 2011. And you have to ask yourself then, what's going on, and what preventative and screening measures are we failing to do in these geographical locations where they are getting this serious disease causing this pandemic. So if you look at geographically in the United States, who is getting it? It is, again, the minority populations, and specifically, Louisiana, Florida, Georgia, New York, Maryland, DC, with Pennsylvania being affected at a rate of 14.3. Unfortunately, I wasn't able to get local intra-hospital statistics. There was an HIV/AIDS support network with the Guthrie, which dissolved its relationship with them a year ago, and with the time constraints, I couldn't get local rates. But screening and prevention, there's approximately 1.2 million or more HIV cases in the United States. 40,000 or more of them are estimated to occur yearly. About a quarter of these people are thought to be unaware of their status. And early screening is tantamount to initiating earlier treatment, because it is proven to increase life expectancy, and especially screening pregnant women, because treating infected pregnant women does reduce the risk of vertical transmission. Another reason why I chose this topic is because by addressing HIV in the primary care setting, it reduces the stigma associated with the disease. And we can get appropriate treatment for those who need it, and identify those who are at risk, and get the screening for them. And also the proper education and counseling. And you may think that's just redundant, but if we have those preventative and screening measures there for these populations, we can maybe interrupt this pandemic. For example, there was recently in the news a gentleman who was charged with infecting over 300 of his partners. And the reason he gave, at least I saw in the news, was he was embarrassed to tell his partners. So, I mean, if he had the appropriate education and counseling, I'm not saying it would have intervened, but maybe it would have. What are some of the preventative measures that are out there? Well, male circumcision was looked at in 3 randomized controlled trials in 2002 conducted in Africa to see whether it decreased the risk of HIV acquisition in heterosexual men having sex with women. And there was a 2009 meta-analysis. You'll see that most of the studies that I quote here are the highest level of evidence and are either systematic reviews Cochrane reviews or meta-analyses. And this showed that men who were circumcised having sex with women, infected women, had decreased the risk of acquisition of HIV by 38 to 66% over a 2-year period. This is significant. And yet, none of this this circumcision in men is not